Good evening, colleagues. Welcome here to another session on bipolar disorders. And today we'll be talking about management. I'm your host, Raymond Mugume. I'm a psychiatrist. Our presenter is none other than Dr. Kemi Mbe. For today, at the end of the Q&A, we shall have a poll, so endeavor to stick around and participate in the poll. And I welcome everyone who is on board, faculty present. And without further ado, I will give Dr. Kemi Mbe to take us through.
Thank you, Dr. Mugume, for the introductory remarks. Welcome once again to everybody. Thank you for joining us yet again for the Neurotorium series. This week, we've discussed bipolar disorder. We went through the definitions, the history of bipolar, the etiology. We looked at the neurobiology yesterday, and today we shall look at the management of bipolar disorder. So I just want to confirm that my screen is visible. So in our outline today, we shall look at acute treatment, we shall look at the maintenance treatment, and other treatment modalities that are available for bipolar disorder. The history of bipolar disorder treatment has been known from time immemorial, from the 19th century. That's where most of the milestones were. However, the modern diagnostic methods and treatments got developed and really approved in the 21st century. And so many of the pharmacotherapies that we are using right now, they have recently been discovered and approved. So there has been a shift from just treating symptoms of that disease to actually ensuring that function is also restored to as much as possible, to the extent possible. So in the 19th century, like I said, there were developments, lithium was discovered, and I was really fascinated by the story of lithium because it was a junior doctor that discovered it. He had been held as a prisoner of war. And during the World War in 1949. So he observed these extremes of mood. He observed that some of the fellow prisoners were very hyperactive and euphoric, others were very low and melancholic. And he, thinking about the person that found that uric acid was contributing to gout, he said there must be something also in the urine of these people that explains their symptoms. And when he got out of, when the war ended, he actually went into psychiatry. He got samples of urine from people who were depressed mood and those who were manic. And he administered this urine to guinea pigs. So the ones that had received the urine from the manic patients started manifesting manic symptoms. And the ones that had got that from the depressed started having low energy, really acting depressed. And he was encouraged to continue with his research. He got started experimenting, and lithium was one of the most common salts at that time. And he said, why not give these guinea pigs lithium and see if this effect shall be reversed? And indeed, the effect was reversed. So that marked the big discovery. He wrote a paper. He hasn't been really acknowledged because other people took it on and did the conventional clinical trials. So since that time, lithium has been acknowledged as a gold standard for treatment. And when that was talking about just lithium because it's the oldest and long-standing, but there are very many agents, as we shall see. And we should not forget that this disorder is of a progressive nature. And so we need to aim at not only handling the acute symptoms and alleviating them, but also preventing relapse in future and ensuring that function is as normal as possible. So you can see this continuum where we have the features that are happening in the episodes. With treatment, a patient with bipolar disorder is assured of a better prognosis, better functioning, less risk of having relapse. You can see on maintenance, the blue side, the right, towards the right, that the episodes are more dotted. So that dotted line depends on whether you're able to get the right treatment for the patient and maintain it. So when we come to our guidelines for acute treatment of mania, we should always remember primarily our goal is to restore the individual's functioning. But during the acute phase, we want to deal with the current mood episode, the intensity of the manic symptoms. And so, yes, apart from having our key goal of restoring judgment, which will also help with treatment, because remember, the symptoms come with an impaired judgment, with lowered insight, which can cause high-risk behavior, including non-adherence to treatment. So as we review the guidelines, we have to have all this in mind, that there are some drugs that we may give for treatment of bipolar disorder, which may worsen the patient's condition. For example, if they came with a major depressive episode and we gave them an antidepressant without full knowledge, we may have a shift of the mood from depressed to manic. So apart from having the standardized mood stabilizing treatments, we shall also look at the other treatments like the psychological treatments. We have to recognize the fact that our mainstay of treatment is the mood stabilizer. However, when it comes to depression, it is quite controversial because, yes, someone has a depression which needs to be treated, but we are bordering on having this depression change suddenly into a mania. So there are some antipsychotics, as we shall see, which have been observed to have antidepressive effects, and at the same time, they will lower the possibility of getting somebody into a manic state when our goal was to treat depression. So, sorry. To avoid all this, we remember our key concept yesterday, that this disease is heterogeneous, so individuals will present differently because of the different factors that come into play. That their family histories are going to be different. The factors associated with the mood symptoms themselves are different. The events surrounding them in their environment are different. So it's important to tailor every intervention to a particular individual. That means you account for their clinical features, their history, their comorbidities, and their preferences. So there's a systematic review which was done, and it found that people who are at high risk of getting many episodes of bipolar, of mania or depression in their bipolar disorder, were doing much better on aripiprazole combined with psychological interventions. However, these studies have lacked evidence from further trials. So there's still a lot of research, for example, to convince the clinical community to only put somebody on an antipsychotic and psychological interventions, much as in a particular population this worked. So it's going to be more individualized as we go along, and we can look at these pharmacotherapies in more detail. Excuse me. So this is, I'm sure some of the drugs here, we are not commonly using them. Like I had told you, we can always take advantage of these therapies which have multiple indications, like quetiapine, which we are seeing there in the middle, which can treat acute depression, which can treat acute mania in bipolar disease, and at the same time, it can be used as maintenance therapy. Then we have lamotrigine there, one of the mood stabilizers, which is basically only used for maintenance. We will not find, you'll not find us prescribing lamotrigine for acute management. So the approach to bipolar 1 is similar to the approach to bipolar 2. There are some studies which have tried to verify whether really the same treatment is equally effective in both, but not much has come out of them. And so the treatment is basically the same. So when you see the treatment guidelines we are going through, it will apply to both bipolar 1 and 2. Let us expose ourselves to guidelines from elsewhere. CANMAT is the Canadian Network for Mood and Anxiety Treatments. So the CANMAT guidelines have 5 major steps. And when we are pharmacologically treating acute bipolar mania, the first step is to review the principles which we have just seen and the medication status. What are they on? What is the patient on? What did they take for their very first episode, and what has helped them to be stable up to this time? And in any case, has the treatment made them stable, or have they not had any treatment before? So there's a hierarchy that they follow of first-line monotherapies for acute mania. That's lithium, quetiapine, valproate, acinapine, aripiprazole, paliperidone. We shall see them. Risperidone. All those are first-line, and they can be used as single therapies. But there are times when we do double combination therapy. So the ones that are usually used in combination, lithium with an antipsychotic, many times quetiapine, or sodium valproate with an antipsychotic, whether quetiapine or risperidone, depending. For our setting, it would really depend on availability. There's a hierarchy also for the second line combinations, but for now, let's finish reviewing the steps. So the second step in the guidelines is to initiate therapy. The very first step, you are looking at this individual, examining them, seeing whether there could be another cause of the symptoms. Remember, we said bipolar is comorbid with other conditions, and somebody may come in with intoxication, alcohol use disorder, and they are having, they are restless, they're having several symptoms which overlap with the symptoms of mania. So we first check the medication status. We initiate therapy with the first line. The first lines are there, I had said them, and then we monitor adherence. Usually, it has been noted that people with bipolar disorder, within 1 to 2 weeks, there's an improvement in their condition. So if no response is observed in those 2, there's need to reconsider the dosage, because if we increase the dose and the patient is not adhering, it doesn't help. Then the third step is to add on or switch therapy to an alternative first line. So if the patient is not responding to an adequate trial of a first line therapy, we can do a combination therapy or get an alternative first line. Since there are many alternative first lines, it's recommended to try several before going on to step 4, which is to switch or go to a third-line therapy. I know for us, first line, second line, third line depends really on availability. So there are also the role of psychological treatments. We shall look at them. But our key takeaway from here is that lithium has been identified as the gold standard therapy because it's effective on the mania, on the acute mania, and even the adverse effect profile is not bad, and it helps even with maintenance. It helps to keep the mood stable for a longer time and reduce the incidence of relapse. There are several therapies that are approved for acute mania, and we shall be seeing them and seeing the evidence for them. So the treatment of bipolar depression, the basic principles are the same. We review the patient, we check their status, initiate the therapy, in this case, quetiapine, lithium, lamotrigine, or lurasidone. So you're seeing that we are treating bipolar depression, but we are not running to get an antidepressant. We are aware that this extreme of depression is part of a bigger disorder. So it's not a major depressive episode. So it doesn't entirely call for an antidepressant. However, a mood stabilizer should be able to treat the depression adequately. And the treatments have to be titrated and tried at the best dose for a response. We first check within 2 weeks, and usually the depressive symptoms have reduced by that time. So if there's no improvement, we can always switch to the second line. So the second line includes valproate or a selective serotonin reuptake inhibitor, an SSRI. Or a second line here for depression. Remember, we haven't rushed into antidepressants. We've started with a mood stabilizer, we've adjusted the dose, and if the dose refuses to work, we do a selective serotonin reuptake inhibitor or electroconvulsive therapy, or a combination of olanzapine and fluoxetine. We shall see that in the CANMAT guidelines, they like that combination. ISBD is International Society for Bipolar Disorders. I realized I was only telling you the CANMAT, but they prefer a combination of olanzapine fluoxetine, it's right there, to treat acute depression, plus those other medications. So lithium is included in some guidelines for treatment of bipolar depression, but its efficacy in the acute depressive symptoms is not as clear as its very obvious efficacy on acute manic symptoms. So with lithium, there's no question about its effect on mania, but the effect on depression is still not as evidenced. So it's basically important for mania and for preventing occurrence of any mood episode, whether depression or mania. So it's still controversial to use antidepressants, as we saw. But there are some studies which have shown that the antidepressants, when someone has a major depressive episode and yet they have bipolar, they work. And the International Society for Bipolar Disorder Task Force reported that if somebody has had a stable bipolar disorder, and if they do not have a rapid cycling, or and they also do not have mixed features, episodes with mixed features, it is safe to use the antidepressants. However, if you have a patient who comes in and they have had 4 episodes or more in the year, or they have had an episode where they had mixed features, that one, giving them an antidepressant would destabilize them. So there are some drugs that are off-label for, I don't think I should go into them because we don't have them here, but even beyond pharmacotherapy, there's evidence that favors modalities like electroconvulsive therapy and psychotherapy for people with bipolar depression. So the mechanism of action of mood stabilizing agents is not really entirely understood. We know them as anti-epileptic treatments, and we also know that they have an effect on inositol uptake, and they balance they modulate the balance of GABA and glutamate signaling in the brain. So at least that is thought to be responsible for their efficacy in stabilization of mood, their modulation of the GABA glutamate signaling. So we can see from the table on the left that lithium is used in acute bipolar mania and for maintenance. Carbamazepine is used in acute disease. Lamotrigine is used for maintenance, and valproate is used for acute mania. When we look at, okay, this is just comparing. There are systematic reviews which have been done, and because lithium efficacy was being attributed to previous studies, so better rigorous clinical trials, which were more modern, were done. Excuse me, and this is the result from all those different organizations. The BAP is British Association for Psychopharmacology, Canadian Mood Treatment. I had already told you the International Society for Bipolar Disorder. So they are trying to place lithium in the guidelines. What do all these guidelines, where do they position lithium in the treatment of the different episodes of bipolar disease? So you can see majority of the guidelines placed lithium first for treatment of bipolar mania. For treatment of depression, what's RANZP is Royal Australian and New Zealand College of Psychiatrists. You can see some placed lithium as first for bipolar depression, others placed it as fifth, and we have just seen that it's not reliable for depression, much as there's some evidence of its efficacy. However, for prevention of manic episodes, you can see from on the third row, almost every guideline recognized lithium as a potent preventer of a manic episode. So that's about lithium. We can go to sodium valproate. Oh, sorry, to valproic acid. So this slide is summarizing evidence of a systematic review for the use of valproate in treatment of acute mania in adults with bipolar disorder. So for the adolescent patients, it was a bit less clear, and other special groups like mothers were not included because we know that it can be teratogenic. So women in childbearing age, we have to avoid it unless we are very sure of the pregnancy status or contraception program that the person is on. And so when it was compared with placebo, patients who were treated with valproate had a 1.5 chance greater chance of response. Then compared with carbamazepine, the chances of response were higher at 2.4. Compared with haloperidol, it was 1.8. And compared with lithium, it was 0.8. So the only therapy which put valproate in a second position was lithium, as we have seen. So the antidepressants, like we said, they're not really what we would run for as a drug of choice. The use of antidepressants in people with bipolar disorder has always been a source of controversy. And there have been small effects of their use from the meta-analysis done. And so the evidence in support of their use is really little, but there are still, in spite of that, there are still some few studies that have said, well, antidepressants can be used. And you can see this meta-analysis where 1,383 people found that there was a small improvement in depressive symptoms. SMD is standard mean difference. That was the difference, such a small difference between whether you used an antidepressant, whether there was an effect with antidepressant and with just the mood stabilizer. So our take home is the antidepressants are not a first line when we are treating bipolar depression. So when we look at the psychosocial interventions used for bipolar disorder, the Depression and Support Alliance surveyed over 2,000 people with the bipolar disorder and their family members and caregivers. So when they found that the majority of the respondents, about 87%, took the recommendation, the medication, but only 54% were getting psychotherapy as well. So the ones who were actually part of support groups were only 10%. And yet there's a lot of evidence that psychotherapy is very effective in bipolar disorder. This survey showed that much of the attention was put on pharmacotherapy, which is not wrong because that's the mainstay of treatment. However, the figure of having just over 50% on psychotherapy raised an alarm because of the available options, which were proved to be very effective. So there's a need to do psychoeducation. And really the purpose is to ensure that the patient is able to understand their disorder. They can tell the symptoms, they can elucidate the causes, they know the cause of the disease, they know how this disease is likely to progress and what outcome they can expect. So we are providing, if psychoeducation is not just for the patients, for their empowerment, but also for the family, for their caregivers. And it has been seen that when it's delivered as an adjunct to the pharmacotherapy, which is the standard of care, it really, really greatly reduces the frequency of mood episodes, and this is documented. So that is just a bit of data on the efficacy of psychoeducation. So there are different therapeutic approaches to treating bipolar disorder. The slide may be too small for you to see, but I encourage all of us to go back to the Neurotorium website. All these resources are available. However, I'll go briefly over that there's when these approaches are added to pharmacotherapy, we reduce the risk of relapse, we reduce the burden of symptoms on patients, not only on patients, but also on their families. So one of them is the interpersonal and social rhythm therapy. It is typically administered as individual therapy, but has also been used for groups. We have family-focused psychotherapy. This is done quite a lot in our setting because the main caregivers are usually family members, and they are given exercises to help them improve communication, because usually when these people come in disease states, that their relationships have been impaired, their communication has been broken, so there is need to open the communication, to reopen the communication avenues and ensure that the caregivers and the patients are in one accord. Then cognitive behavioral therapy, this can be administered for groups or individuals, and it helps the patients to recognize their maladaptive thoughts and link this to their moods. They are also able to use exercises, structured exercises, to identify the thoughts and record their mood and their activities, and it really helps them to manage the aspect of disease that they can. So there's a lot more on psychotherapy. There are studies that have been done to show that as an adjunct to pharmacotherapy, psychotherapy does reduce the frequency of mood episodes, it reduces length of hospital stay, and it increases adherence to medication. So these were there was an analysis done in favor of many psychotherapies, as we can see, the CBT, family therapy, and compared to those who were given treatment as usual, those that got the psychotherapies in conjunction with the pharmacotherapy were favored in terms of outcome. This is still showing us the strength of evidence for adjunctive psychosocial treatment. Psychoeducation is usually first line, and it's very easy to administer. CBT is second line, and so on. The peer support, family caregiver interventions, and all these support the use of these psychosocial interventions. So as we treat our patients, let's not only pump them up with medications, with pharmacotherapeutic agents. Let us remember that the causation was linked to all these areas, to the environment, to the genetics, and so even the management has to be biopsychosocial. What other interventions are available? We have electroconvulsive therapy. I know we have recently had a discussion on ECT, and it was used in the 1930s, and it was quickly observed that manic symptoms usually responded quickly to ECT. However, it has been underused because of the stigma associated, even amongst us, the health workers. Sometimes it's an issue of availability because you need an anesthetist or anesthesiologist, and there has been also some apprehension about the possible side effects. Then there's transcranial magnetic stimulation, which is non-invasive, and it makes use of an electromagnetic coil placed over a patient's scalp, and certain regions of the brain are targeted with the magnetic pulses. So there are a few studies on the use of TMS in bipolar mania, but they concluded that it may favor resolution of manic symptoms, but they still haven't been conclusive enough. Yes, please. Yes, I've been online. At what point did you lose me?
At this slide.
Oh, sorry about that. Is the slide still visible though? Overview of psychopharmacological maintenance treatment.
Yes, it is.
Okay, thank you very much. Thanks for the heads up. So we have seen that many of the pharmacological treatments for management of acute manic or depressive episodes are also used for management, for maintenance. And so when we are considering what to use for maintenance, we should have the first drug you consider is the drug that has been used and has been effective in the acute phase and can also actually be used for maintenance. And when we saw in the other table, we saw that many of the drugs that were used in the acute could be used for maintenance. That's the mood stabilizers. However, once maintenance has been initiated, we still need to continue to monitor them in order to get the best out of the therapy, and also to prevent relapses, and to ensure that there is adherence, good adherence to treatment. And at each point, the patient's tolerability to each drug needs to be assessed, because there are times when they are uncomfortable with medication. And if they don't speak about this, they'll end up being non-adherent, and then the efficacy of that drug will be reduced. So this table is similar to the other one, because it's this. Now we are looking at maintenance. The other one was we were looking at acute, but we know that there are many drugs that are used, and I think I didn't tell you about, there are many long-acting forms of the antipsychotics that are used these days to stabilize the patients, and as well as the acute treatment. I think I probably didn't mention that there are times when a patient needs to be kept in the hospital for observation, but also for other forms of treatment apart from parental treatment, apart from that. So this is showing us the efficacy of pharmacological maintenance treatments and their adjuncts, comparing lithium and olanzapine, plus all the other antipsychotics you can see in the list at the bottom, and the mood stabilizers. So when the meta-analysis of these RCTs, of the randomized controlled trials, was done for maintenance drugs in bipolar disorder, olanzapine, quetiapine, and asenapine showed the highest efficacy. Let me try to get my pointer. But they showed the highest efficacy over placebo, and the risk of subsequent mood disorders was lowest among the atypical antipsychotics, lithium, and the other mood stabilizers like lamotrigine. The ideal mood stabilizers exerts both antidepressant and anti-mania effects. And although lithium is not as effective in depressive symptoms, once someone has depression and you combine it as the mood stabilizer with the psychological interventions, it has been shown to be effective. The clinical profile of these anticonvulsants that we use varies depending on what phase the illness is on. For example, carbamazepine and valproate have proven to be very good for maintenance and treatment, for maintenance and prevention of mania. However, lamotrigine has been seen to be more effective against depression than mania. So this is still in favor of lithium as maintenance. Remember, the other time we were looking at lithium for acute management and valproate and all these drugs. Now we are looking at them for maintenance treatment. So they can be used in monotherapy, as we had seen, or combination therapy. But please remember, don't forget that valproate can have teratogenic effects on fetal development, causing cardiac malformations and other malformations. And actually, in women of childbearing age, a higher incidence of polycystic ovarian syndrome has been reported with valproate. So we have to be very careful when we are prescribing it to women of reproductive age. So lamotrigine has been approved. We have seen it in a meta-analysis that was done. It was found to have overall similar efficacy to lithium. However, it had a higher risk of recurrence of manic symptoms. Remember, we said lithium has been found to have the lowest risk of recurrence of manic symptoms. So in a long-term study of patients with bipolar depression and mania, lamotrigine was found to be more efficacious than lithium for maintenance. What it does
Dr. Kemi
is that,
Mbe,
yes, please.
could you work on summarizing. We're out of
Okay.
time.
Okay, thank you very much. I think the antipsychotics, I've talked about them before. I've talked about combination. This slide is just highlighting how much time will it take with a combination to get another episode than if you don't have a combination. So if you have a combination, it will take 15 months. But if you have only lithium, it will take 10.5 months. Only valproate, 7 months. So 57% of patients don't adhere because of that profile, and there's other factors like attitude to the medication, social demographic factors. If you don't have a support system, a relationship with family, and they can support you to take your medicines, it's very difficult to adhere. These are the guidelines for antidepressants, which we had already talked about, that if someone is not rapid cycling, and they don't have mixed episodes, they can use antidepressants. What are the limitations of our existing pharmacotherapies? One, the mood stabilizers like lithium have a narrow therapeutic index. They have long-term thyroid and kidney damage. So one of the reasons we don't routinely use them is because we have to keep doing thyroid function tests, renal function tests, which may get expensive. There are other limitations of using the other drugs. Carbamazepine has a high risk of Stevens-Johnson's. If we have seen that disease, it's really devastating. Valproate has warnings for hepatic damage, teratogenicity, hepatotoxicity, weight gain, and antipsychotics. We know that it's extrapyramidal side effects, the sedation, the metabolic disorders, increased prolactin. This is just an overview of the different populations which we should consider when we are prescribing the pregnant mothers, children, and the older adults. So this is just a summary of the comorbidities, which we already looked at, that many psychiatric disorders concurrently with an additional disorder, but bipolar by far occurs with the most disorders, including heart disease, diabetes, metabolic diseases, thyroid disease, and so on. So it's important to monitor not only the psychiatric aspects of the patient, but also the general medical condition. Acute treatment, we have talked about alleviation of the immediate symptoms. And once these are alleviated, we can ride into the maintenance treatment. And there are many which have been approved for acute mania. I hope we shall have a small discussion on what we are using mainly here in our setting. But in addition to the pharmacological treatment, psychotherapy is much indicated. Maintenance, we have seen the drugs that help us to reduce the incidence of future episodes, those that help us to actually stabilize the mood, return back to better function, but all these in conjunction with the psychosocial treatments. Thank you so much. Thank you for listening and participating and for your patience.
Thank you, Dr. Kemi Mbe, for that presentation. Colleagues, we have a poll that is going to be shown. I will ask Dr. Moses to guide us on how to participate in the poll. As you also give us your questions and any suggestions or any comments regarding our session so far. This is week 4, and we have been talking about bipolar disorder. I would like to think that everyone is not the same like the way they began when we started on Tuesday. And thank you, Dr. Kemi Mbe, for dissecting the topic to the core.
Thank you.
Please, I'm giving you like 2 minutes to just participate in the poll. We are waiting for you to participate in the poll. If you're not having difficulty, please raise your arm and or type in the chat so that that can be addressed. There are a few questions that have come up, and I would like to read them out so that we can be good with time. One, I don't know if Dr. Biragwa is on the call. But Dr. Birabwa is a consultant psychiatrist at the National Referral Hospital here in Uganda, the Butabika National Referral Hospital, and is also the member of the International Organization or International Society for Bipolar Disorder. And and she's very, very more than passionate about bipolar disorders. So every time we have had discussions or anything to do with bipolar disorders, even as students would still refer to her to give us her expertise and wisdom and guidance. But I don't know if she's on call to later on come in. So the first question is from Sandy Apollo, who asked, what are some of the antipsychotics that have antidepressant effects?
Okay, thank you, Sandy. The most highlighted one we saw in the intersection of those circles, if you can remember, it was quetiapine, but others like paliperidone, aripiprazole have also been highlighted to have some antidepressant effects, but the most common being quetiapine.
Okay, thank you for that clarification. Then we have Dr. Stephen, who asks that for patients who are stable on mood stabilizers for first episode bipolar disorder, when can you consider drug holidays? And the second question is, how best can we help patients cope with the side effects of mood stabilizers, especially weight gain?
Right. Thank you, Doctor, for those questions and participants. First of all, the drug holidays. When we are starting this treatment, it's recommended to tell them that a mood stabilizer is a long-term treatment. We give them the disclaimer that this may be lifelong. Many people don't want to hear that at the beginning, and there are actually people that have been weaned off the treatment. So it's not entirely that everybody will have to take it for life, but it's much safer to have that understanding that most likely this is going to be for life. So drug holidays are not really generally not recommended unless somebody has really been episode free for 3 to 5 years. Somebody has been documented to come for their treatment. They've been coming for assessment, for review, and they have registered at a period of stability up 3 to 5 years without any relapse. Those ones can be considered for a drug holiday. So we can have a trial of medication, usually starting with 2 weeks, increasing as necessary, but it has to be a very low risk case. What do we mean by a low risk? For example, if you're from a family and you don't have family history of bipolar disease, of bipolar disorder, and you've got the bipolar disorder, that family history is not strong, you're a candidate for our drug holiday. Also, if maybe this was the first episode of mania, you got diagnosed with bipolar disorder, you never had another episode of mania, and this is 3 years after the first episode, and you have not had another episode, that one is also a candidate for drug holiday. So it's generally not recommended to really rush into drug holiday unless you've spent several years on treatment and you are stable. The other question was about managing the side effects, right?
Yes, please.
So um,
The
managing
question
the side
was,
effects, yes.
how best can we help patients cope with side effects of mood stabilizers, especially weight gain?
Okay. So how best can we help patients? Now, those issues, we handle them. It's not so different from somebody who the mechanism in the body is not so different from somebody gaining weight when they are not on an antipsychotic. You know, usually most times the antipsychotic is causing the weight gain. So we handle it the way we normally handle. We tell them the basics of a healthy lifestyle, which we all should have at our fingertips. Exercise, eating food in moderation, and having a balanced diet. Because, you know, much as these drugs may increase the appetite, if you fill yourself with a lot of water and a lot of roughage, a lot of fruits, a lot of vegetables, it will be very difficult to gain that weight, but some may be beyond the patient's control. We've seen that there are changes, impairment in metabolism. So what we can do, the service we can offer to such a patient who has no control over this weight gain, it's purely metabolic, is to check before we start them on treatment. We do their lipid profile. We even keep checking during the treatment, so that if we notice any changes, it's best to have a drug that wouldn't, for example, you know that if you are to give olanzapine, it has been documented to bring almost the highest weight gain compared to the other antipsychotics. So if you do these lipid profiles, if we are monitoring them and we are noticing that they are getting deranged, it's much better to switch than let the patient suffer the consequences of that excessive weight. Otherwise, the conventional method, we encourage exercises, to take a balanced diet and avoid those foods that would cause a lot of weight gain.
I think in
Thank you.
addition to what you just said, one of the things that I think we need to always take into consideration is, I think for most patients that we see, we need to always do their waist circumference, measure their body mass index, as well as measure their height from the beginning before you start the therapy, and then 6 weeks into the therapy, and then on depending on, again, on a particular patient. This is really tailored by individual. When we talk about exercise as a prescription, usually we think that patients usually come off as if we are saying that they should be fit, but the aim is not really about exercise as exercise. Maybe we can think about it as movement, and movement in low intensity, then moderate intensity, and then high intensity. And there is what we call the FITS program, which is about the frequency, intensity, the time, and the type of exercise as well that you can recommend, which you can get online, which you also will find in the Neurotorium slides, okay? So those are some of the things, but one other thing that I think we can do for the patients is to tell the patients the side effects of these drugs, okay? The ones that have been documented, and then you hash it out with the patient on which ones can they tolerate. Because there are some, like if you say weight gain, there are some, if you also gauge that the person is slim, has not been eating, maybe putting on some weight is good for them. But if they have already had, maybe they have one of the symptoms is eating too much as one of the symptoms, you want to really consider a drug that, like Dr. Kemi Mbe has guided, that doesn't have one of its side effects causing weight gain. So those are some of the things that we need to daily monitor for our patients, and again, to always check with them on the treatment plan, because sometimes we give them the treatments and yes, they disappear or they have challenges that we might overlook. But when they come in, we still say continue treatment. So maybe we also need to get into the habit of continuous monitoring once we have, you start afresh in terms of assessment, not continue treatment, continue treatment, continue treatment. Thank you. Musa Muhammad did express his heartfelt gratitude to the organizing team and to the presenter, Dr. Atkunda, for delivering a comprehensive and enlightening session on bipolar disorder. That your dedication presenting evidence-based knowledge and clinical expertise is truly appreciated and greatly benefits all participants. I have a question that I believe is particularly important to address. And the question is, what is the most effective way to tailor treatment plans for individuals with bipolar disorder. Considering the variability in response to mood stabilizers, antidepressants, antipsychotics, and adjunctive therapies to prevent relapses and improve long-term outcomes. Dr. Kemi Mbe?
Yes, Dr. Mugume. Could you please read?
The
I was trying
question
to put it in the chat.
so the question is, what is the most effective way to tailor treatment plans for individuals with bipolar disorder?
Okay.
In consideration of the variability in responses to these mood stabilizers, the antidepressants, the antipsychotics, and the adjunct therapies to prevent relapses and improve long-term outcomes. Just to break it down before Dr. Kemi Mbe comes in, I think she did mention it, that you need to look at the factors that that do interfere with adherence to treatments, okay? One of the things that we need to have as clinicians is that patients are different. That's for sure. However, within our setting, we still rely on data that has been carried out in countries outside, okay? And so what we are doing within our context is that we want people to be involved in mental health research so that then we can collect enough data. We need enough data to inform our practice here. However, until we get the data, what can we do as clinicians? What we can do as clinicians to tailor these treatments and have it in mind about the variability in treatment responses is that you need to take a thorough history. A thorough history is very important. A mental state exam is very important. Doing a physical examination is very important. And listening to your patient, because I think some of the things that we do struggle with as clinicians is listening to the patient, because again, we have long lines we need to clear. So we need to get into the habit of listening to the patient. If the patient comes in and says, you gave me quetiapine, it's giving me headache. As much as maybe headache was not one of the side effects you would have expected, listen to them, because that is data that they are giving you. You need to listen to them and adjust and understand how this headache started, and maybe tease out if it was either because of the quetiapine or something else came in. The other thing that we need to do is how we can tailor our treatments to our patients is we cannot stay in the habit of continue medication. Continue. You come in the first episode, quetiapine, the second, quetiapine. But then every other time you're not reassessing the patient, you're not monitoring the side effects, you're not carrying out the tests, the blood tests. We are not maybe even doing the MRI, because some of the things that could be causing your mania could be an organic cause, okay? So we need to individualize treatments in terms of how we take the history, how we physically examine the patient, the tests that we do, and the conversation, the story that the patient is telling you, rather than using a one size fits for all. I think that's what I would contribute. But Dr. Kemi Mbe, you can take up more to give us your response.
Thank you, Dr. Raymond. I think you've really comprehensively answered. I can just add that maybe we consider what came first. Was it a depression? Was it a major depressive disorder? Was it a manic episode? And when it happened, which drug was effective? You take it from there. The drug that is effective in acute is the drug that is a good candidate for maintenance. Otherwise, I think you handled the other aspects. And since it's the top of the hour, we can always continue to engage with Mohammed out of this meeting, but you've really answered it comprehensively.
Thank you, colleagues, for once again spending your time with us. We as the organizing team from the Neurotorium, we are more than grateful for your attendance. Do not forget, next week we shall be here again starting Tuesday to Thursday, and we shall be dissecting the topic on anxiety as Dr. Katama has already said in the chats. And again, endeavor to tell your friend, to tell your neighbor, to tell your other colleagues that are in other departments to attend. We're here really to deepen the topic of neuroscience about mental illnesses within the practice. And without further ado, it is at the top of the hour. I look forward to seeing you again next week. Have a good evening and bye-bye.